Es un placer para mí saludarlo, doctor Moisés Quiles, a su mesa directiva y a todos los participantes del 23 Congreso Nacional de Neonatología. Asimismo, al 13º Congreso de Enfermería Neonatal 2023, decirles que estamos muy emocionados en Puerto Vallarta. Puerto Vallarta es un destino que cautiva, que enamora, no solamente por su clima, sino por su ambiente, por su gastronomía, por sus actividades adicionales a su prestigioso evento. Los esperamos en Puerto Vallarta, esperamos ser sede de su gran evento. Seguro estoy que se irán cautivados de un destino tan importante y tan hermoso como Puerto Vallarta.
Hola, muy buenos días. Soy el doctor Raúl Garza, vicepresidente del Consejo Mexicano de Certificación en Neonatología, en Pediatría, sección de Neonatología. Y bueno, de parte y a nombre del doctor Moisés Quiles, presidente de la Federación Nacional de Neonatología de México, y de la doctora Dener Morales, presidenta del Consejo Mexicano de Certificación en Pediatría, sección de Neonatología, quiero darles la bienvenida en este sábado 8 de octubre, empezando ahorita a las 11 de la mañana, con esta sesión académica de la Federación. El tema de la sesión es requerimientos nutricionales del recién nacido, muy prematuro, con un peso extremadamente bajo al nacer, por el doctor William Hay, a quien van a presentar muy bien a continuación. Mucho gusto y nuevamente bienvenidos y gracias por estar aquí con nosotros.
Muy buenos días a todos. Tenemos el gusto el día de hoy de presentar al doctor William Hay. Es profesor jubilado de pediatría y neonatología en la Universidad de Colorado. Daremos también algunos detalles de su trayectoria. Antes de jubilarse fue director del programa de salud materna e infantil en el programa de exposición temprana y el Centro de Investigación Translacional Clínica, Neonatal y Perinatal del Instituto de Ciencias Clínicas y Translacionales de Colorado. Se desempeñó como director científico del Centro de Investigación Perinatal. La investigación del Dr. Hay se ha centrado en la nutrición materna y el transporte de nutrientes placentarios, así como la nutrición y el metabolismo fetal y neonatal. Ha estudiado cómo proporcionar la nutrición del bebé prematuro, que sea similar a la nutrición del feto en crecimiento normal a la misma edad gestacional. Esas investigaciones se han centrado en cómo prevenir la limitación de nutrientes en el crecimiento postnatal, particularmente en el avance en la nutrición enteral y parenteral. El Dr. Hay es reconocido a nivel nacional e internacional por su experiencia en trastornos del metabolismo de la glucosa en recién nacidos, así como en la nutrición de los bebés prematuros. A continuación vamos a estar en coordinación con la doctora Mercedes, quien nos dará también una leve introducción de los comentaristas.
Sí, muy buenos días, gracias. Pues sí, es un honor para nosotros coordinar este webinar 114 de la Federación de México de Neonatólogos con la compañía pues del doctor con este gran tema. El doctor Alberto Santana, él es el actual presidente de la Asociación de Neonatólogos de Tabasco, y Mercedes Mercado, su servidora de Baja California, de la Asociación de Baja California, y pues estamos muy complacidos de coordinar este webinar. Como ya comentó el doctor Santana, el doctor William Hay, pues es el ponente de este tema del día de hoy, y en compañía con nosotros también agradecemos a los doctores Bisuet y al doctor Bunners que nos acompañan como comentaristas al final de la exposición. Van a hacer algunos comentarios y me permito presentarlos a los doctores. El doctor Raúl Bisuet, que nos acompaña esta mañana, es pediatra neonatólogo, es jefe de neonatología del Hospital Regional Adolfo López Mateos, académico de pre y posgrado de pediatría y neonatología, es expresidente de la Asociación de Médicos Neonatólogos del DF y Valle de México, también es expresidente del Consejo Mexicano de Certificación en Pediatría Sección Neonatología y miembro de la Academia Mexicana de Pediatría. Actualmente profesor de pediatría en la Universidad del Valle de México. Nos acompaña también, como ya nos hizo la introducción, el doctor Raúl Garza Bulnes. El doctor es actualmente vicepresidente, como ya comentó, del Consejo Mexicano de Certificación en Pediatría, sección Neonatología, y el siguiente bienio, si Dios quiere, pues nos va a coordinar, va a ser el presidente de este consejo. El doctor, pues es médico neonatólogo también, es egresado de la Universidad de Monterrey como médico general y de pediatría y neonatología de la Universidad de Monterrey en el Cristos Muguerza, con algunas rotaciones que tuvo el doctor en el Children's, en el del niño y la mujer en Los Ángeles, y también algunas rotaciones que tuvo en Texas. Además, pues también tiene maestrías en ciencias de la educación y también en el programa de continuidad de alta dirección empresarial con el Instituto Panamericano de Alta Dirección. El doctor, pues, actualmente también participa en los cursos de reanimación activamente y avalados por las diferentes instituciones internacionales y nacionales, el de reanimación, el PALS, y sí, actualmente también, como les comento, es el vicepresidente y también es académico actualmente en la residencia de pediatría y neonatología. Les damos muchas gracias a los doctores Bisuet y al doctor Garza que nos acompañan y nos harán comentarios al final de la sesión. Y bienvenido, doctor Hay. Le cedemos la palabra para empezar esta excelente ponencia. Doctor Hay.
Dr. Hayes, you can start.
Thank you. Let me share my screen. There we go. Well, it's a very great pleasure of mine to be able to speak to you this morning. about nutritional requirements of the very preterm infant with extremely low birth weight. First off, I do not have any potential or actual conflicts of interest to disclose. I won't be discussing any off-label or unapproved products. Our learning objectives for my presentation today are first to review the goals and the rationale and the importance of sufficient nutrition and appropriate growth rates for extremely preterm infants. I'll review the current status of nutrition of extremely preterm infants, and then the requirements for protein and energy in these infants. I'll also review nutrition that promotes brain growth and neurodevelopmental and cognitive outcomes in extremely preterm infants, since that's probably the most important outcome that we're interested in promoting with better nutrition. I'll review enteral feeding approaches in these infants to achieve better nutrition, and then fortification of maternal and donor milk to meet protein and energy requirements in these infants. So first, what are the goals for feeding preterm infants to provide nutrition for these special infants? And the first is the most important, to achieve growth rates comparable to those of the normally growing healthy human fetus. For example, the infant growth parameters that follow the Fenton or Olsen growth curves, since all other aspects of development follow normal growth. The second then is to prevent extrauterine growth faltering, the failure to grow at a normal rate in the neonatal intensive care unit. And then obviously to optimize neurodevelopmental and other long-term outcomes. The American Academy of Pediatrics recommends that parenteral and enteral nutrition should provide nutrients to approximate the rate of growth and composition of weight gain for a normal fetus of the same post-menstrual age. So those are our goals, and we now start with what is the normal fetal growth rate, if that's what we're supposed to achieve. And it's very clear that among many, many different studies, including over 6 million infants less than 37 weeks and over 100,000 infants less than 33 weeks, the birth weight by gestational age is relatively constant from about 26 to 37 weeks, the period we take care of preterm infants, at 15 to 20 grams per kilo per day, depending on the population, some being big, some being small, with an average of 17 grams per kilo per day. And I think you can see very clearly in this figure that no matter which one of these studies you look at, the slope is positive and straight, meaning that the average growth rate of 17 grams per kilo per day is one that we should try to match for our preterm infants. But to measure a preterm infant's growth rate, it's essential that the growth rate calculations are done when an infant is growing, because growth does not begin at birth. Normal preterm infants lose about 5 to sometimes up to 15% body weight as fluid losses over the first few postnatal days. And this can be augmented by some undernutrition during this early postnatal period. So the actual growth rate is best calculated after the infant starts to grow. After the lowest weight after birth, the nadir weight, or after the day the birth weight was regained. You can see in red that the calculating growth rate from birth, the birth weight, actually underestimates the actual growth rate. That's a fairly flat curve, and that 6 grams per day calculated from birth to some later gestational age, in this case 30 weeks, is falsely low. Whereas if you start calculating from when the baby's lowest weight occurs, the nadir weight, or the day the birth rate was regained, you see that that slope is positive. It follows the 10th percentile, or just above the 10th percentile, and approximates 12 grams per day, an appropriate weight gain. So measuring the baby's growth when the baby's actually growing is fundamental. And when the baby doesn't grow well, we can say that baby has postnatal growth faltering. And here is an example of a preterm infant with postnatal growth faltering. This infant had a weight less than 10th percentile at 36 weeks. And many people would say that means the baby has growth faltering or growth restriction. But this baby also grew at less than normal fetal growth rates for weight in the lower panel, length in the upper panel, and head circumference in the middle panel. So this infant clearly did have postnatal growth faltering. Its growth was not following the normal fetal growth curves. In contrast, this infant also had a weight less than the 10th percentile at 36 weeks. But as you can see from these curves, the baby grew at normal growth rates. It followed the fetal growth pattern almost exactly. And that was true for weight, length, and head circumference. This infant, therefore, did not have postnatal growth faltering. And why can I say that? That's because defining postnatal growth as a weight less growth faltering as a weight less than some arbitrary growth percentile at any arbitrary time will include normally small infants from genetically and constitutionally small or short mothers, as well as their fathers, and normal infants who grew according to normal fetal growth rates after the postnatal weight loss, largely due, as I pointed out, to water losses and undernutrition. And also because there is no evidence of adverse neurodevelopmental or other adverse outcomes among infants who simply weighed less than the 5th or 10th percentile, but grew at a normal fetal growth rate. And because in very preterm infants, very low birth weight infants, the course of postnatal growth, rather than some appropriateness of weight for gestational age, determines later neurodevelopmental outcomes. So the main point of this is that being small is not abnormal. Failing to grow at a normal rate is. So why is it important to achieve normal fetal growth rates? And that's because the approaches that achieve normal fetal growth rates in extremely preterm infants have the strongest potential to improve both current and longer-term outcomes. As you can see in this figure, the green bars show infants that followed the growth curve, the fetal growth curve, and in the blue bars, those that had growth faltering. And you can see that within the neonatal intensive care period, those infants that followed the growth curve had a much lower rate of bronchopulmonary dysplasia, a much lower rate of necrotizing enterocolitis, a significantly lower rate of sepsis, both acute, early, and late onset sepsis. And that's true for the acute period, but even longer term outcomes. You can see that the infants that followed the growth curve had a lower rate of cerebral palsy when studied later in life. And when studied in school age, they had much fewer school difficulties. So clearly, following the growth curve reduces the incidence of these particular abnormal outcomes. So does early nutrition in a preterm infant's postnatal life matter? And the answer is clearly yes. This is one very nice study that looked at first week protein and energy intakes and showed that they were positively associated with better 18-month developmental outcomes in these extremely preterm infants. In this first week, every 1 gram per kilogram per day increase in protein intake is associated with an 8.2 point increase in mental developmental index at 18 months. And that's true for females and males. And every 10 kilocalories per kilogram per day increase in energy intake in the first week is associated with a 4.6 point increase in mental developmental index at 18 months. So very clearly, making sure that nutrition is positively supportive in the first week of life, very early in the postnatal period, is fundamental. Preterm infants also are in critical developmental stages when nutrient supply clearly and directly affects growth and development. You can see the positive slope of this blue line where fat-free mass gains in preterm infants, primarily produced by better protein intake, was positively associated with cognition at 4 years. These cognitive associations with fat-free mass were not seen in term infants, and that's because they are not in critical developmental stages. So fat-free mass gain associated with better protein intake is positively associated with neurodevelopment in preterm infants because they're in this critical developmental stage that is not the case for those infants born at term. What is the current status of nutrition in preterm infants? So how are we doing if we're supposed to meet these fetal growth curves and provide better developmental outcomes? Fortunately, there clearly have been improvements. This is data from 2013, but it's clearly much better than shown earlier in 1999 in the National Institute of Child Health and Development studies. That's the green dotted lines. And you can see whether the infants are born at 24 weeks in the upper right, the 26 to 28 week infants at birth in the lower left, and even 30 weekers in the lower right, that clearly over that 12 to 15 year period, growth is improved. The babies are better following their growth curves, their weights are higher at every gestational age. So they clearly were doing better. But even these curves show that growth rates of extremely to very preterm infants less than 30 weeks are still less than normal fetal growth rates. So all of these infants did have postnatal growth faltering. So there's still much room for improvement. So why don't preterm infants grow as the normal fetus does? Well, many of these infants are stressed and physiologically unstable, and some are actually sick. And all of these infants are undergoing treatments. And all of these conditions and all of the treatments are catabolic. That is, they break down protein and use up energy stores. But from a nutritional perspective, most of these poorly growing infants are simply not fed enough food. And that's true as evidenced by cumulative deficits, not at any one point, but over a longer period. These data are over the first month of life. And you can see cumulative deficits in energy in the upper left and protein in the lower left, even with more aggressive feeding. And the aggressive feeding was shown, defined as on day one, birth day, 1.5 grams per kilo per day of amino acids, plus 5.6 milligrams per kilo per minute of glucose. And those were increased to 4 grams per kilo per day of amino acids and 13 milligrams per kilo per minute, respectively, for protein and glucose by days 4 to 5. So a fairly good start and a rapid advancement. Similarly, lipids were started on day 1 at 0.5 grams per kilo per day and increased to 3.5 grams per kilo per day by days 3 to 4. So very clearly, even with this more aggressive feeding approach, there still were large cumulative deficits in energy and protein. And so these infants were destined to not be able to grow well. Now that was in 2006, and unfortunately, we're still not always meeting nutrient requirements, particularly in the first week of life. This is data from only a few years ago, 2017. And you can see for protein in the upper left, lipid and carbohydrate, and energy in the lower right, it's clear up to day 7 to 8 before the required amounts of protein, lipid, carbohydrate, and energy are achieved, allowing this baby to grow at a normal fetal rate. So why aren't preterm infants fed enough to grow as the normal fetus does? Well, that's because of several reasons. The first and probably the most important is that too many times nutritional goals are set at less than the amount needed for normal fetal growth rates. Feeding volumes and nutrient amounts, particularly of protein and energy, are simply insufficient to produce growth. We also delay starting nutrients. We may provide no or even low rates of intravenous amino acids on the first to second day of life, to sometimes several days after birth. And often enteral feedings are held sometimes for days, particularly in the smallest and sickest infants. We use dilute nutritional mixes once the baby is being fed, insufficient essential amino acids in our intravenous TPN mixes. We use unfortified milk, mother's milk or donor milk, when feeding volumes are low. We slowly advance nutrient supplies. Even when we're starting amino acids early, we may not advance them to full amounts very quickly. And similarly, we say days and days before we get up to full enteral feedings. Nutritional deficits and delays are not prevented, and thus they accumulate. So intravenous nutrition may be weaned too fast ahead of slowly advancing enteral nutrition, leaving the baby undernourished for extended periods. And then way too often, feeding is interrupted for a variety of reasons, which we could have a whole conversation about. For example, the baby is sick with RDS and can't be fed, maybe. Baby's on a ventilator, well, maybe. Feeding intolerance, whatever that is. We check it by gastric residuals, and every time you check with a gastric residual, you may not feed the baby when it still could tolerate feedings. And all of these are largely due to a fear of necrotizing enterocolitis, the main reason why babies often are not fed as they could be. All of these causes can be prevented or at least reduced, which can prevent or ameliorate growth faltering. So let's look at the principal nutrients, protein and energy. So for protein, how much is needed to grow the normal preterm infant as a normal fetus? Protein requirements are really relatively constant. Nitrogen retention or protein balance in preterm infants is directly and linearly related to protein intake. Each one of the dots along that line are from a different study. This figure was created by Nick Embleton from Newcastle, United Kingdom. And very clearly, you can see that that's positive, that slope is positive among these studies of different protein intakes. Very clearly, you need at least 1.5 grams per kilo per day of protein intake to produce growth. And you need 3 to 3.5 grams per kilo per day to produce 300 milligrams of nitrogen retention per kilo per day, which is approximately 2 grams per kilo per day of net protein gain. And guess what? That's exactly what will produce 17 grams per kilo per day of body weight gain, which, as I've already pointed out, is the average growth rate of the normally growing human fetus. Well, that was among many different studies. Even this outcome is true even right after birth and even in physiologically unstable infants, when there is a direct correlation between amino acid supply and protein balance. These infants were started on intravenous feeding, and they were studied before 48 hours after birth. Exactly the same results, a very tight correlation, a very positive relationship between amino acid intake, showing you need at least 1.5 grams per kilo per day to start growing, and you need at least 3 grams per kilo per day to produce that 2 grams per kilo per day of protein balance, which is going to produce that 17 grams per kilo per day of average normal fetal weight gain. But the amount of nutrition that we provide, amount of protein that we provide, can vary over gestation because growth rates decline. The very smallest infants have a growth rate that's a little bit higher than it is later in gestation. So the 500 to 1,000 gram infants have a growth rate of around 20 to 23 grams per kilo per day. But by term, that's dropped down to 12 to 14 grams per kilo per day. So it's important to provide the right amount of protein at the right time. You can see in the red circles that between 24 and 30 weeks, amino acid requirements are quite high, 3.5 to 4 grams per kilo per day, to support that higher fractional growth rate that these infants have and the higher fractional protein synthetic rate. But growth rate and fractional synthetic rates decline with gestational advancement. So between 32 and 37 weeks, protein requirements for growth decreased to 2.5 to, at the highest, 3.5 grams per kilo per day. And at term, protein requirements decreased to those of the normal breastfed infant, or about 1.5 to 2 grams per kilo per day. So if your baby is born at 24 weeks, you're going to need a much higher protein intake. If your baby is born preterm at 32 to 37 weeks, less protein intake compared to the term infant. As I've already pointed out, it's important that you maintain energy and protein supplies. So in this case, if your goal protein intake is 3.5 grams per kilo per day, and you wean your IV, intravenous nutrition, shown in the hatched areas of these bar graphs, too fast before you advance in the open bars, the enteral nutrition, you end up with a considerable period of accumulative protein and energy deficits, which clearly are going to prevent this baby from starting to grow and to continue to grow once growth has started. You can prevent that problem by, as shown in the upper left, by more slowly reducing your parenteral intake and more rapidly advancing enteral intakes, so that you maintain protein intake at least 3.5 grams per kilo per day and maintain energy intakes at least 120 kcals per kilo per day by slowly reducing your intravenous amino acid intakes and energy intakes and advancing your enteral feeding sooner. And as you can see on the right, if you need less fluid intake by your intravenous approach, you can, for example, when you're starting to advance your enteral feedings, you can concentrate your parenteral nutrition, which will maintain protein energy intakes and thus better weight gain without excess water balance. Clearly, you can see that the weight standard deviation scores were much higher over the first 28 days of life with the concentrated TPN solution versus the original, which was a lower one. And in the lower right, you can see some examples. If you use a very dilute 3% amino acid solution at a reasonable starting fluid rate of 80 mils per kilo per day, you will provide this infant with some amount of protein sufficient for starting growth to 2.4 grams per kilo per day. But if you needed more protein intake, you could give a 5% solution, a concentrated solution at the same fluid rate, and get up to 4 grams per kilo per day. But what if you want to reduce your fluid rate by intravenous route even more, say 50 mils per kilo per day? You could concentrate your amino acid solution to 7%, and that would provide 3.5 grams per kilo per day. So over many years, the most consistent observation has been that more protein intake produces greater protein retention and thus the capacity for greater growth rate. As you can see here in the figure, whether you're using human milk that's not fortified or human milk that is fortified, it's not the diet, it's how much protein is in it and how much protein is delivered that shows better protein retention for increasing protein intakes. That's protein. How about energy? How much energy do preterm infants need to grow as the normal fetus does? And this cartoon from Dr. Jean Micheli from a number of years ago shows very clearly that energy requirements above are necessary to support protein synthesis, but above 80 to 100 non-protein kcals per kilo per day, there's no further increase in protein accretion for an increase in energy intake. So you can see in the white circle on the left, at lower energy intakes, 50 to at the most 70 to 80 kcals per kilo per day, protein accretion is augmented by more protein, but also more energy. The excess, the additional energy reduces the amino acid oxidation. That favors net protein synthesis or growth. On the right, you can see, however, that at higher energy intakes, while protein accretion still is augmented by more protein, it is not augmented by more energy. Those curves are flat. So if you added more energy at that point, you would only produce more body fat. And that's very clearly shown in this data from a number of studies that Dr. Sudha Kashyap from the University of Columbia provided a number of years ago. And you can see very clearly that the normal fetal fat requirements producing that normal amount of body fat in the third trimester of energy stored 35 kilocalories per kilogram per day is done at 100 kcals per kilogram of energy intake. So if you're providing 120, 130, 140, 150 kcals per kilo per day of energy intake, there's a very positive slope of stored energy. And I wonder if that might be producing preterm infant obesity. So very clearly, excess energy is going to be positively associated with excess energy stored. And that could be, that is clearly going to add body fat. And that's nicely shown again in Dr. Kashyap's study. You can see a group of preterm infants with a variety of weights at birth. On the left, the dotted bars these infants were fed a modest amount of protein, 2.2 grams per kilo per day, and an appropriate amount of energy, 115 kcals per kilo per day. When those infants were provided more protein at the same energy intake, now up to 3.6 grams per kilo per day of protein intake, the weight went up in the open bars in the middle. The length went up in the open bars in the middle. The head circumference went up in the open bar, but tricep skin fold, a measure of body fat content, didn't change. That same protein intake was then supplemented with excess energy, 150 kcals per kilo per day. And reflecting on that figure I just showed you, that should provide more body fat, but not more protein gain. So yes, as you can see in the hatched bars on the right, weight did increase, but length did not, head circumference did not, those lean body mass measurements did not increase with the excess energy, but tricep skin folds did. So excess energy is not going to do anything but produce more body fat, whereas protein will always be producing more protein gain. And these interactive plots show very clearly with individual data on the left or the surface average plot on the right that both protein and energy, calorie intake, are positively associated with protein balance. More protein intake, up to 3.5 grams per kilo per day in this study, greater protein balance. More energy, up to 100 kcals per kilo per day in this study, greater protein balance. But the combination of more protein and more energy intake produced the greatest protein balance. Both are necessary to produce the most positive growth in our preterm babies. But I suggest some caution, because while sufficient nutrition is fundamental, excess is not better. These are data from MRI evaluations, magnetic resonance imaging studies of the brains of preterm infants. And as you can see, energy increasing up to 107 kcals per kilo per day, positively associated with better MRI scores. And that energy was accomplished by more fat intake and more carbohydrate intake. And that same increase in better MRI scores was also achieved with more protein intake. In this study, up to 4.3 grams per kilo per day. But notice that these curves flatten out. There's really no point, no benefit to better growth, or in this case, better MRI scores, when there is simply excess energy, fat, carbohydrate, or excess energy or excess protein provided. And excess of these substrates can be harmful. Excess energy and excess protein have been associated with producing systemic hypoxia, reduced anabolism or growth, toxicity, actual toxicity of glucose, amino acids, fatty acids, a risk for unbalanced tissue development, as I've just shown you, more fat, more relative to lean mass. You can also increase oxidative injury and inflammation, both locally in tissues and systemically, and therefore risk of worse neurodevelopmental outcomes. These are the American Academy recommendations for energy and protein, whether given parenterally at the top figure, part of the figure, or enterally at the bottom figure. I think we've covered these very carefully now, and you can see that these are reasonable amounts that we should try to achieve for our preterm infants in these very low birth weight, very preterm period. And these data are very similar to those published recently in Nutritional Care of Preterm Infants by Dr. Koletsko and colleagues, or as recommended by the European Society for Parenteral and Gastroenterological Committee on Nutrition. So a fairly common approach for the amounts of parenteral or enteral energy and protein intakes. Next, let's look at what diet promotes brain growth, since we're primarily interested in producing a baby that not only gets bigger, grows, but also produces a better brain, both larger and more functionally capable, including cognitive outcomes. A nice review by Barbara Cormack from Auckland, New Zealand, was a meta-analysis of multiple studies. So these are results from looking at a large variety of studies, some observational and some experimental. And what she noticed that from birth to 36 weeks, the strongest positive association with increase in head circumference Z-score was from mean total protein intake in weeks 2, 3, and 4. So that's improved brain growth, very clearly associated with better protein intake. And even as early as week 2, infants with a lower total protein intake had less than half the odds of achieving expected head circumference growth from birth to 36 weeks. But interestingly, by week 3, those infants that were still receiving intravenous protein, this was negatively associated with the Z-score change in head circumference as well as weight and length. But I suspect this is because this likely reflected that these infants had less enteral nutrition, providing insufficient total nutrition, including especially protein. And also perhaps these infants were sicker and more unstable, who couldn't tolerate enteral feedings, and thus were more catabolic and required more IV nutrition which is less nutritionally optimal than enteral nutrition. And the more protein intake you get, well, you get some benefits from providing better growth factors. In this case, I show you some very nice data for insulin-like growth factor 1, IGF-1. These are serum levels over the first 28 days of life and correlated with regional brain volumes at term equivalent age. And very clearly, you can see that higher IGF-1 levels directly related to better protein intake were associated with, in the upper left, greater total brain volume, in the upper middle, greater amounts of white matter volume, in the upper right, greater amounts of cortical gray matter volume, in the lower left, more deep gray matter volume, and in the lower right, total cerebellar volume. So very clearly, more protein intake, higher IGF concentrations. IGF independently will promote better growth of the brain. So protein intake increases, IGF-1 increases, and that's not true just for growth of the brain, but also for producing a cognitive outcome later in life. So this is over the postmenstrual period from 25 to 36 weeks, and you can see the higher protein intake producing the higher IGF-1 concentrations resulted in higher mental developmental indexes, those higher, more of them higher than a score of 85, whereas lower protein intake, lower IGF-1 levels, lower MDIs. So clearly, protein intake can benefit not only by its structural contributions to structural growth, but also in promoting a growth factor, IGF. It's also important to remember that human milk is fundamentally important for growth of the brain and its cognitive outcomes later on. So here's a study looking at the dose of human milk in the NICU and baby, preterm infants, and their outcomes first at 18 months, and the same data was noted in these infants when studied again at 30 months. Very clearly in the red bars, in the red lines, mental developmental index and the psychomotor developmental index in blue, positively associated with increasing percent of human milk intake. Clearly getting up above 40 to 60% of total feeding as human milk intake, positively associated with better neurodevelopment and cognitive outcomes. And that was shown quite a few years ago when Alan Lucas did a study of infants, and not just looking at these at 18 months or 30 months, but at 8 years of life. And while there were a variety of factors associated with the infant's IQ at 8 years of life, receipt of human milk had the highest effect on producing a better IQ, plus 8.3 points. In a population, that's huge, and that's a significant amount, even in an individual baby. And when those same infants studied at 8 years were then studied again in adolescence, 13 to 19 years of life, it's still the case, very significantly, that the greater percent human milk intake was associated with increased adolescent brain volumes, both total brain volume and total white matter volume. And the greater percent human milk was associated with positive increase in adolescent IQ, especially in boys who always need some more help, as well as all infants. Very significant outcomes, even up through adolescence. And the more exclusively you can provide a human milk diet, the more likely you are to have better cognitive outcomes. In the middle there, you can see a cognitive composite score that was significantly better. It was an exclusive human milk diet was used, 96.5 points versus 89, highly significant whether unadjusted or adjusted p-values were addressed. And this was, the adjustment was for birth weight, sex, the center, and necrotizing enterocolitis. So very clearly, moving as much as you can to a total human milk diet has a positive effect on neurodevelopmental and cognitive outcomes. So summarizing what is important for brain development: mother's own breast milk primarily, also enteral nutrition, not intravenous nutrition, although intravenous nutrition is fundamental to get started right after birth. And then over time, the cumulative macronutrient, protein and energy intakes. And lean mass gain, primarily due to more protein, is the one that's most associated with larger brains and more mature white matter microstructure. So what about enteral feeding of these infants? It's really fundamental that while we need to start these infants on intravenous nutrition, we need to move very quickly to enteral feedings, and do this with trophic or gut priming feedings in most cases over the first several days of life, advancing to full enteral feedings. And when you do that, you can see growth on the figures on the left is improved with enteral intake as a percent of total feedings. This involves mucosal growth and development, which depend on enteral, not parenteral nutrients. And if you only feed parenterally, the gut doesn't grow or develop. Enteral feeding improves motility and blood flow to the gut. It improves feeding tolerance and growth. It provides less need for phototherapy. You flush bilirubin downstream. Therefore, you get decreased cholestasis. You get better calcium and phosphorus intake, so reduced osteopenia in the bones. You get gastrointestinal trophic hormones surges, which improve gut growth as well as body growth. And when this is done, there is no increase in most of the recent studies in complications, specifically necrotizing enterocolitis. And that's particularly true when these infants are started for their trophic or priming feeds with colostrum and early mother's milk. So how soon after birth should we start enteral feedings? In this study, they compared in phase 1, the black dot data shown in the middle there, with infants that were started on day 1 with full enteral feeding. All of these infants in the phase 2 and phase 3 periods received full enteral feedings as the day's fluid requirement since the first day of life. And when that was done, compared to those infants with delayed feeding, you can see that there was significant decreases in the day of full feeding achievement, day of regaining birth weight, the incidence of NEC, the incidence of sepsis, the duration of antibiotic therapy, intravenous therapy, and duration of hospital stay. So starting as enteral feeding as much as you can on day 1 of life clearly is beneficial. How fast should we advance feedings if we start on day 1? A Cochrane database systematic review in multiple periods, 2008 through 2015, showed that currently available data do not provide evidence that slow advancement, less than 24 mils per kilo per day of enteral feeding volumes, reduce the risk of necrotizing enterocolitis, but they recommended more study needed. And one very good study, therefore, was done in the United Kingdom, the SIFT study, a controlled trial of 2 incremental milk feeding rates. And they noted that 30 mils per kilogram per day compared with 18 mils per kilogram per day advancement in feedings did not increase the risk of necrotizing enterocolitis. So there was clearly benefit to advancing faster than had been done in the past. Too many people measure gastric aspirates. The idea is that if there's a large gastric aspirate, you might not feed. And often that the stomach is aspirated and that food is tossed away, getting rid of a lot of important acids and gastric hormones. So here was a study in which about half of a group of infants, less than 32 weeks and less than 1,250 grams birth weight, were randomized to no gastric residual evaluations. And this group of infants had faster feeding advancements by about 3 days, greater feed consumption by weeks 4, 5 to 6, so over time, higher mean estimated weights, fewer episodes of abdominal distension. They were discharged 8 days earlier. That's huge. And similarly, and they had similar GI-related morbidity to the group that did have gastric residual evaluations. And you can see that those involved GI motility, feeding intolerance, intestinal inflammation, bleeding, abnormal microbiome, neck, late onset sepsis, and so forth. So the take-home message is that routinely evaluating gastric residuals before every feeding is unnecessary, and in fact, it could be harmful. So there's no point in doing that. Should we follow standardized feeding guidelines? And the answer is clearly yes. There's many studies. They essentially all show improved nutrition and growth of preterm infants when standardized feeding guidelines are used. I give you one reference there where there was decreased time to full feeds and central line utilization among infants who received standardized feeding guidelines. And why might this be the case? Well, at least for one reason. A recent analysis of feeding orders found 2,550 unique feeding combinations over a 1-month period in just 2 NICUs in the United States. That's huge amounts. So why does this matter? Because reducing diversity maximizes using what works best and more often and more consistently. So the best you should do is devise your own guidelines and follow them very carefully. What are appropriate milk feed fortification approaches, whether you're using mother's or donor milk? There are several fortification strategies. The most commonly used is blind fortification. It's based on the assumption that human milk fortified protein content 1.5 grams per deciliter, an energy content of 20 kilocalories per ounce. Problem is that nutrient content variation is not factored into this fortification standard process. And the resulting milk probably has less protein and energy than the fortifier label content suggests. It's just easiest to do to add a standard amount. You could use an adjustable fortification process. This is usually done based on serial blood urea nitrogen measurements, but this assumes inaccurately that changes in BUN are specific surrogates for protein intake. BUN can vary a lot by just simply how much urine the baby is producing. And then the more recent approach is using milk analyzers to provide targeted individual fortification. This standardizes composition of fortified milk to provide a consistent and defined amount of macronutrients, but it hasn't really transitioned into clinical practice. First, because these milk analyzers have not been available. They're very expensive. They require personnel and special resources. And to date, there really has not been that much favorable data showing that this works much better than blind or adjustable fortification. But I think you'll see these instruments coming along, and they will be used more to adjust protein and energy intakes with a diet balance with fortification. Fortifying milk does increase nutrient intakes at the same volume intake, 160 mils per kilo per day. The fortifier from 20 up to 24 calories per ounce definitely increases protein intake, energy intake, calcium intake, and sodium intake, all necessary for growth. And in fact, that growth actually takes place. As you can see here, the fortification of human milk increased weight gain significantly, length gain, head circumference gain, bone mineral content, nitrogen balance, and yes, even BUN, because the protein was oxidized, producing, and the liver was working so that ammonia produced from oxidized protein was turned into urea. There was in these studies, there was no increase in feeding tolerance, necrotizing enterocolitis, or mortality. So fortification does significantly and clinically positively affect growth and a variety of other factors. Fortification also may be specifically necessary in our very preterm, very low birth weight infants. As you can see here, the fortified group had a positive slope in weight gain versus milk volume intake. The non-fortified group did not. So fortification is specifically valuable, not just an increase in feeding volume in these extremely preterm infants to achieve a positive weight gain. The true protein concentration, as you can see in the blue area on the left, is highly variable though. So a given mother's milk may have very high protein intakes, grams per 100 mils, even up to as high as 4 to 4.5 grams per kilo per day, especially in preterm infants. And those infants are not going, those milks from those mothers are not going to require fortification, because even at normal fluid volume intakes, normal feeding intakes, there's plenty of protein available. But in the lower left, you can see that some of these mothers are producing milk, even preterm mothers producing preterm milk, are going to have very insufficient amounts of protein. And fortification will be necessary starting right after birth with the earliest of the milk that mother could provide. But by 2 weeks of life, almost all of these milks are going to be insufficient in providing enough protein to meet growth requirements. And so after the first 1 to 2 weeks of life, fortification of milk is needed in all of these cases. But many of these infants still, even when the fortification is provided, are still not growing well. And one study done by Ariel Salas at the University of Alabama showed that in those infants, additional supplemental protein can promote growth. So he studied these infants at 25 to 28 weeks, and they were randomized to either standard fortified maternal or donor milk, or infants that got the standardized fortification, but an additional 0.75 grams per 100 mils of extensively hydrolyzed protein. The added protein fortification increased the total protein intake to the maximal recommended amounts, 3.5 to 4 grams per kilo per day. But interestingly, this did not involve increased energy intake. All of these infants got the same energy intake. So the extra protein added to standard fortification, as you can see on the right, clearly over the first 2 to 3 months of life, increased weight gain, length gain, fat-free mass gain, and head circumference, but did not increase fat mass. So if your infant isn't growing well, excess protein may be beneficial. What about bone mineralization? A major problem in all of these very preterm infants, as measured by alkaline phosphatase, indicating poor mineralization. You can clearly see in the upper curve, unsupplemented human milk resulted in shorter lengths of these infants at 18 months and shorter height, even up to 9 to 12 years of age. And all of those were reduced, if not improved, to normal values when either preterm formula or fortified milk was used, as you can see in the lower bar. So how much does fortification provide? You can see the calcium and phosphorus requirements on the left, that are 184 milligrams per kilo per day for calcium, 126 for phosphorus. You can see that fortified human milk, surrounded by blue there, 156 milligrams per 100 kcals, still less than the required amounts, significantly less amounts of phosphorus. But the human milk that was fortified was still pretty good when compared with preterm formula. That provided the greatest amount of calcium, but not sufficient amounts of phosphorus. So fortified human milk and preterm formulas with more calcium and more phosphorus might help bone mineralization, but both might still need more phosphorus as well as supplemental vitamin D. And then there are other supplements that people are addressing right now. And one of the most interesting and apparently most significant in terms of improving growth and developmental outcomes is the use of zinc. And you can see here that whether you're looking at low birth weight infants in black or very low birth weight infants in red, that weight, length, total neurodevelopmental score, and motor neurodevelopmental score were all positively associated with supplemental zinc. Zinc dosages are fairly standardized for less than 1,000 gram infant, 2.7 to 3 milligrams per kilogram per day. Even if the baby's only on intravenous nutrition, about a third to a fourth of that is fundamental for supporting growth with the parenteral nutrition. This will correct the zinc deficiency that results in poor growth, increased risk of infections, the well-known skin rash when very severe and prolonged, and the poor neurodevelopmental outcome that associates with the poor growth. I found one small randomized control study of zinc supplementation, 6.6 versus 0.9 milligrams per kilogram per day. The group that had no supplement had more neck and higher mortality rates. That was the placebo group. But the group that got supplemented with zinc up to 6.6 megs per kilogram per day clearly did not have beneficial weight gain. So there's still more to learn about this, but I think supplementing with zinc has a potentially very good positive beneficial role for growth. So to summarize, preterm infants should be fed sufficient nutrition to meet the growth rates and body composition of the normally growing healthy human fetus of the same gestational age. Currently, however, nutrition is often insufficient, and that's clearly associated or causes long-term deficits in growth, neurodevelopment, and cognitive outcomes. Gestational age specific intakes of protein, for example, 3.5 to 4 grams per kilo per day for the very preterm infants, and energy 100 to 120 kcals for the same early gestational period, should be provided for extremely preterm infants, which of course then tapers towards ad-lib demand breastfeeding after 34 to 36 weeks. Sufficient nutrition of both protein and energy that achieve normal fetal growth rates is directly related to increased brain growth and longer-term neurodevelopment and cognitive outcomes. Enteral feeding should start as soon after birth as possible and be advanced as fast as tolerated. Maternal milk should be used as much as possible. Donor human milk is acceptable, but both of those are going to require fortification most of the time for longer, even though longer-term studies are going to be needed to assess the impact of fortification, particularly when exclusively human milk fortification is used to produce better neurodevelopmental and cognitive outcomes. So thank you very much. My goal was to show you that the baby on the left, the extremely preterm, very low birth weight infant, becomes the baby in the middle, a normal Denver, Colorado Chicano baby, not the baby that's very growth restricted or the baby that's very fat like an infant of a diabetic mother on the right. I look forward to your questions. And for those of you who don't have the capacity to ask a question or get one answered, you can send emails to me with your questions. I love to get follow-up email questions, and I'll be happy to respond to those. So thank you very much for your attention.
Muchísimas gracias, doctor Hay. Vamos a continuar y ceder la palabra a los doctores Garza Bulnes y al doctor Bisuet para que hagan los comentarios en la sesión, ¿verdad? Que nos ilustren un poco con sus comentarios y enseguida pasamos a la sesión de preguntas y respuestas. Adelante, doctor Bisuet, si gusta empezar.
Muchas gracias. Doctor Bill Hay, sé que le gusta que le llamemos Bill. Quiero hacer un comentario. ¿Qué ha sido de aquellos niños en los que la única fuente de energía era la glucosa? Después se utilizó una fórmula a base de corazón de res y finalmente se les ponía aceite de girasol en la piel para aporte de ácidos grasos esenciales. ¿Qué es de aquellos niños hoy día? Porque hoy tenemos el futuro más cerca y mejores condiciones para nutrir a nuestros bebés. Muchas gracias ante todo por la plática, la experiencia y la motivación.
Thank you so much, doctor, for the time, the experience that you're giving us, the motivation. I know you like us to call you Bill, Dr. Bill.
That's
Doc-
fine.
There is comment. What has it been with those kids that before they were given glucose, they were giving this recipe that was with the cow's heart and with the sunflower oil? What has happened to those babies now?
Could you repeat the question? I'm sorry, I didn't quite get it. The sound is not clear.
Yes, sorry about that. What has happened? What has been the development with those babies that, you know, instead of giving them the milk, the fortifiers, when we used to use glucose, when we used to use the bull's heart, when we used to give them sunflower oil?
Yes, so the balanced fortification has clearly shown improved growth outcomes. Simply providing an oil does increase some energy intake and did increase weight, but the fortification process with the balanced fortifiers does a better job of providing more protein, more salts, sodium particularly, as well as more energy. And the lipid that is in those fortifiers is primarily medium chain triglycerides, which are more rapidly absorbed and contribute to energy production better. So actually the growth of these infants has improved. The supplement with when we use just polyglucose or some complex carbohydrate, there often was diarrhea and it just simply did not improve growth that much. So a balanced fortifier clearly is a better approach.
Muchas gracias. Yo quisiera dejar el micrófono a Raúl Garza o a la sesión de preguntas. Muy interesante plática, doctor. Muchas gracias.
Bueno, muchas gracias, doctor Bisuet y doctor Bill Hay. Muchas gracias nuevamente por su presentación, una excelente presentación. Yo creo que los comentarios finales usted los resumió en su penúltima diapositiva o imagen, y es lo que nos recuerda de tratar de iniciar la vía enteral, la vía oral lo más pronto posible y estar cuidando la proporción de energía y proteínas, lo cual es algo que es sumamente importante por todo lo que usted ya nos comentó ahorita. Definitivamente, y en los últimos años creo que hemos regresado a esto de tratar de que sea la leche materna el alimento principal de estos bebés, aunque sean prematuros. Y bueno, quiero aprovechar y hacer una pregunta respecto a la proteína, porque el mismo doctor Koletsko tiene reportes en los últimos años, más que todo en niños de término, de que una dieta elevada en proteínas en estas primeras etapas de la vida puede conllevar a problemas metabólicos y de otros tipos, no nada más en la etapa futura de la vida, sino en etapas tempranas. ¿Y qué pasa con los prematuros? ¿O qué es lo que estamos viendo con los prematuros actualmente en cuanto a la cantidad de proteínas que le estamos administrando?
Thank you, doctor. This definitely reminds us that we need to start enteral nutrition as soon as possible and to keep an eye on the proportion, as you mentioned clearly, of the protein and the energy. I think that we've come back in the last time to focus on mom's milk, to give the babies the mom's milk, even if they're preterm. So I want to ask, a diet that's elevated in protein, there's some studies that show that it could have some metabolic problems, not only later in life, but in the first stages. What are we seeing with this preterm babies?
There's been considerable concern for excess protein. Up to 3.5 to 4 grams per kilo per day is appropriate, and I know of no study showing a problem with that amount of protein. The real concern has been whether we should provide 4 grams per kilo per day of amino acids intravenously starting on day 1 of life. Professor Nina Modi from London has been particularly concerned about that problem. Our group at University of Colorado and Children's Hospital of Denver really has not shown that that's a problem. And the study that Dr. Modi did not, was a retrospective study. So there is still a positive, an experimental study going on. It's just that it's usually biased because the infants that are on intravenous nutrition very early on are often those that can't tolerate advancing enteral feeds. And intravenous nutrition is not the best nutrition, enteral feeding is. Longer term outcomes, yes, if you take a baby that's already gone home and you feed that baby extra protein as well as extra energy, there's an increase in insulin production and the potential for increasing fat mass. But that's after the baby has gone home, not during the neonatal period, when very clearly, if you don't provide sufficient protein for as well as the supportive energy to achieve normal growth rates, you're going to end up with growth faltering and adverse outcomes. So I don't see, as I pointed out very clearly in one figure, excess protein and energy intakes, particularly excess amino acid intake, is not going to be beneficial and could be potentially harmful. So stick with the right amounts at the right gestational age, and I think the babies will do just fine. A very good question. Thank you.
Okay.
Muy buena pregunta, gracias. Menciona que el exceso de proteínas, ¿no? Él había mencionado que pues es 3.5 a 4 gramos. Es apropiado, que él sabe que no hay ningún estudio que muestre problemas con esta dosis. El problema es si dar desde el primer día ya la dosis máxima, no los 4 gramos. Ahora, la doctora Nina Modi ha estado hablando de este problema. El doctor, aquellos en su clínica en Denver, no han visto que iniciarlo con la dosis máxima sea un problema. Hay estudios experimentales que se están haciendo, pero hay sesgos. ¿Por qué? Porque se está teniendo en cuenta población aquellos bebés que tienen intravenosa desde temprano, desde que nacen, son aquellos que no toleran la vía enteral. Sabemos que la nutrición parenteral no es buena, pero ahora si vemos un bebé que ya se fue a casa y que en casa le están dando más proteína, más energía, obviamente va a haber un aumento de insulina, va a haber un aumento de la grasa. Esto ya cuando se van a la casa y puede generar los problemas, pero cuando están en la UCIN, cuando claramente se les tiene que dar las tasas para evitar que tengan una restricción de crecimiento, él no ve que haya un problema, siempre y cuando se mantengan con la dosis que ya está estipulado, ¿no? Como mencionó él en una figura, el exceso de proteína y energía no es beneficial, incluso puede llegar a ser dañino.
Okay, thank you very much, Dr. Hayden. We are very pleased to have you with us today.
Thank you.
Okay. Sigamos con sesión de preguntas y respuestas, por favor.
Sí, doctor, muchas gracias. Tenemos algunas preguntas. Una de las preguntas es, en caso de no contar con fortificador de leche materna, ¿pudiéramos utilizar las fórmulas prematuros en combinación con la lactancia materna?
Doctor, what about the cases where we don't have milk fortifiers? Can we use the preterm formula with the mom's milk?
Yes, that's been the most common approach. Of course, there's some concern about bovine protein producing inflammatory changes in the gut and even associated perhaps, although not very clearly, with increased incidence of necrotizing enterocolitis. It's not clear whether that's a problem with bovine protein or that the absence of maternal milk is the problem. But at any rate, if you do not have fortifiers, supplementing mother's milk, whether it's mother's own milk or donor milk with a formula is certainly appropriate. As the baby is more mature, you also can simply increase feeding volumes. Another study by the Alabama group, Dr. Ariel Salas's group, showed that babies above 30 weeks gestational age at birth could be fed over the next 2 to 3 weeks up to 180 to even up to 250 milliliters per kilo per day of just mother's milk or donor milk without fortification. And that improved growth better than those infants that did not get the higher volumes. but those were more mature infants who could tolerate the much higher feeding volumes.
Understood. Sí, menciona el doctor que ese ha sido el abordaje más común, ¿no? Cuando no hay fortificadores, mezclar lo que es la leche de fórmula de pretérmino con la leche materna o leche donante. Ahora ahí hay un problema. No sabemos si con la proteína bovina, la inflamación del intestino, tal vez puede llegar a ocasionar enterocolitis. Si esto es por la proteína bovina o si es por la ausencia de leche materna. Pero bueno, si no tienen fortificantes, suplementar la leche materna o la leche donante con una fórmula es apropiado. También conforme el bebé sea más maduro, también se podría aumentar las tomas. Menciona un estudio que se hizo en Alabama, que mostró que con aquellos mayores de 30 semanas de gestación se les puede dar hasta 180 mililitros, 150 a 180 mililitros por kilogramo por día de solo leche materna. Y eso, en comparación con aquellos bebés que no se les aumentaron las tomas, ayuda con su crecimiento, con su desarrollo.
Muchas gracias. La siguiente pregunta, doctor, desde Paraguay, el problema es, comenta la doctora que si estamos con un bebito que ya está comiendo lactancia, o sea, pura leche de mamá, pero han tenido problema para incrementar el peso, sí es recomendable adicionar aceites vegetales y si tiene alguna ya evidencia de la asociación de esto con problemas metabólicos en el adulto.
And doctor, what about the case we have a baby that's drinking mom's milk, enough mom's milk, but they're not gaining weight? Can they add vegetable oil? Is there any information in these studies that show that there's a metabolism issue when the baby grows older?
Excess oil, regardless of which oil you use, vegetable oil or medium chain triglycerides, will increase energy intake, but the baby won't grow that much better unless it gets more protein. So that one study from the Alabama group that showed that even when the baby is receiving standard fortification, additional supplement of protein would show a benefit for protein gain. But when your baby isn't growing, even when receiving full enteral nutrition, even when supplemented, then you really have to look at whether the baby has some other underlying disorders. If the baby had intrauterine growth restriction, did not grow well as a fetus, this reduces the baby's capacity to grow at any time, particularly postnatally, and will not respond to a higher protein intake, and growth rate will be slower. You need to be cautious about feeding babies that had chronic intrauterine growth restriction, because excess protein and energy, even when it's the normal amount for the weight of the baby, may not be tolerated well. So the other thing, of course, is the baby losing stool too much? Is the baby not being kept warm enough? Does the baby have many treatments that are going on? Ventilation, infusion of steroid, infusion of catecholamines, infusion or treatments with steroids like cortisol, hydrocortisone. So many disorders and many treatments can be making the baby incapable of growing even when normal and to maximal amounts of nutrition are provided. So obviously we always have to try to improve health care of these babies, medical care of these babies when they're not growing, hoping that that will reduce their catabolic condition and allow them to respond to the nutrient intakes. Sometimes this may take 2 or 3 weeks to occur.
Claro, menciona el doctor que el exceso de aceites, no importa el aceite que se utilice, esto va a aumentar la energía, pero no va a hacer que crezca el bebé, a menos que aparte le estén dando proteína. Incluso cuando los bebés tienen fortificadores estándar, ¿no? Se podría tomar en cuenta darle un suplemento de proteína. Esto sería algo beneficioso. Cuando el bebé no está creciendo, incluso si ya tiene el suplemento, tenemos que ver si hay algún otro problema. Tenemos que checar si el bebé tal vez tuvo restricción de crecimiento intrauterino, no creció bien como feto. Entonces esto le va a reducir la capacidad para crecer en cualquier otro momento de la vida. No vamos a esperar que estos bebés tengan la tasa de crecimiento. de manera como la normal. Esta tasa de crecimiento va a ser más lenta. Hay que tener cuidado, sobre todo igual como con los bebés con esa restricción, porque incluso cuando el peso del bebé se considere normal y la dosis sea normal, puede ser que los bebés no estén tolerando estos fortificadores, estos suplementos. Hay que ver si el bebé está defecando mucho, si no le está manteniendo la temperatura adecuada, si está con tratamiento de esteroides, si está con catecolaminas. Muchos desórdenes, muchos tratamientos pueden estar haciendo incapaz al bebé de crecer, aun cuando esté en dosis máxima de alimentación. Hay que ver el cuidado médico de los bebés cuando no crecen, esperando ver cómo disminuir el estado catabólico. Y estas son cosas que pueden tomar semanas en lograrse.
Sí, bueno, otra pregunta. En aquellos pacientes que hubo necesidad de usar, por ejemplo, la fórmula para prematuro, ¿qué experiencia tienen con las fórmulas altamente calóricas? Hay algunas fórmulas que dan un aporte de una caloría por mililitro, y que propiciarían a una mayor recuperación en cuanto al peso, pero sin embargo, ver cuál sería la repercusión a largo plazo en esos pacientes, principalmente en aquellos que ya se les está llevando el seguimiento en la consulta externa.
And doctor, what about those patients that we use, that they're needed to use preterm formula, about those high calorie formulas? We know that this would cause a better weight gain, but what are the repercussions for this? What do we need to keep an eye out on, the general visits that they have at the doctor?
The preterm formulas have been shown to produce better growth because they have more protein and energy than term formulas or unfortified milks. And they produce better long-term neurodevelopmental outcomes than term formulas. They do not exceed neurodevelopmental cognitive outcome improvement compared with fortified human milk or human milk when provided at full amounts of enteral feeding. So preterm formulas do work, and they work well, and they do provide sufficient protein and energy intake. They have been associated with the bovine protein with gut inflammation. Whether that leads to NEC or whether it's simply something that happens at the same time is still unclear. So I would look for what we call hematochezia, or blood in the stool, as a sign of inflammation that a formula might, bovine product might be providing. We really don't see any other major complications with the formulas. They've been used successfully for many years, and they've certainly been improved from the early days when I started, when they had too much casein relative to whey protein, and that produced obstruction in intestines with lactobesors. But the more modern preterm formulas are primarily based on whey protein. There is some question of whether a preterm infant might do better with a formula in which the protein is hydrolyzed, broken down into peptides and even amino acids. That seems to work best when the infant has a short gut syndrome, but is probably not beneficial when the baby is otherwise able to tolerate full enteral volumes of feedings.
But what about the high calorie formula?
Yes, the high calorie is again only going to add to more fat production in the baby, and I don't see an advantage to that. Of course, you want to see normal fat production, but that occurs with the normal amounts of energy intake. You really are primarily focused on the protein intake to produce growth and neurodevelopment. The energy is supportive of protein intake. The excess energy, the high calorie supplemental formulas have really not been shown to produce better neurodevelopmental outcomes. They've primarily been associated with increased weight gain, but that's largely been due to increased fat mass gain, not lean mass gain.
Thank you, doctor. Menciona que las fórmulas pretérmino sabemos que tienen un mejor crecimiento, producen mejor neurodesarrollo. Cuando se les pregunta específicamente es para aquellas que tienen alto contenido calórico, no muestra alguna mejoría. Hay una cuestión de por qué esto sería mejor utilizar las fórmulas preterminales. ¿Por qué? Porque estas llevan a un aumento de peso, que es lo que habíamos visto. Aumenta la ingesta de calorías, pero no aumenta la ingesta de proteínas. Entonces tenemos que tener mucho cuidado con esto. También menciona en general que las fórmulas pretérmino, ¿no? Nuevamente, han sido exitosas y ya llevan bastantes años siendo exitosas, sobre todo si se les compara con cuando se habían iniciado, cuando tenían mucha cafeína, cuando hacían opciones. Obviamente hay que tomar en cuenta el riesgo o la relación que se ha hecho entre la proteína bovina y la acción, y que si esto lleva a enterocolitis, ¿no? Que es lo que tendríamos que ver nosotros más adelante con los bebés, datos como hematoquesia en caso, con este tipo de bebés que están con el tratamiento.
Muchísimas gracias, doctor. Hay muchísimas preguntas, doctor, inquietudes, pero por tiempo tenemos que pasar a la despedida. Solamente una última pregunta, doctor, o sea, 2, 3 preguntas de inquietud en el podio. ¿Con cuánto volumen, doctor? Cuando llegan a cuánto volumen de leche materna, supongamos que el bebé está tomando ya 100, 120 mililitros por kilo de leche materna, ¿con cuánto volumen agregan el fortificador? O sea, si llegando a 50, a 100. Y esa es una de las preguntas. Y las recomendaciones a las mamás en la dieta de la mamá. Que si en sus programas de lactancia materna en los bancos de leche están asesorando a las madres en su alimentación y si pueden medir de alguna manera la calidad y que sea en beneficio del bebé. Y también en cuanto a la leche humana que estamos teniendo disponible, ¿cómo saber si es hipocalórica o hipercalórica? Es una de las inquietudes.
Doctor, so when would you recommend on the fortifier? When would you add it? If we're talking about the daily volume of the baby with 100, 120 milliliters of mom's milk, how high would we put it with the fortifier? They mentioned a couple other questions. That and with the mom's milk, is on your programs for the mother's milk and breastfeeding, are they giving any kind of advice, any guidance into any special meal plans, any diet that they have to take? And also, last question is, how can we know, is there a way of checking if the milk is hypocaloric or hypercaloric?
Going backwards, I think I'll remember these. You can repeat them again, but you can use a crematocrit to see whether the milk is rich in lipids. Otherwise, you have to use a milk analyzer, which, as I pointed out, while they're now available commercially, they're expensive and and require special equipment and special training of personnel. But I think we'll see more of those. The crematocrit, very much like a hematocrit, helps identify milk that is low or high, not accurately, but at least a rough guideline to whether it's richer or poorer in fat composition. Repeat the other questions, please.
Of course. The other question is on a mom, when they're breastfeeding and they're in that program of breastfeeding, are they giving any kind of special advice on their diet?
Yes. So we have lactation consultants, and they assist the mother in how to express her breasts if she's trying to provide express breast milk. They certainly encourage her to be at the NICU to help feed the baby, whether she can provide the milk from home or in the NICU. So strong personal encouragement is the best. I don't know of any special diet that really produces more milk or a richer milk. Obviously, if the mother has a diabetic condition, her milk will be richer in glucose, but also then in insulin. There may be some benefit to that in getting the baby started on better nutrition, but for the most part, just a good healthy diet in the mother is recommended. But I think the main thing is helping mothers of a very preterm infant learn how to express her milk and store it at home and then bring it into the NICU if she can't stay at the NICU. And then the first question was when to start fortification. The usual is somewhere, it varies a large amount among different programs, and there's been very little study of this. Most places are starting fortification well before the baby is on full enteral feeding. So in the past, the standard had been to wait until the baby was up to 100 to 120 mils per kilo per day of enteral feeding before starting fortification. But more recently, fortification has been started when the baby's only receiving as much as 30 to 50 cc's per kilo per day of enteral feeding. But personally, I don't know of a study that would suggest that starting fortifier with the first feedings is a problem. I think the main thing to start on is to get the mother to provide colostrum. Again, a nurse or a lactation consultant can help provide colostrum and early milk and advance express milk feedings or advance expression of milk so that the baby can get up to full enteral feedings of mother's milk as soon as possible. Obviously, if you don't have enough mother's milk, you use either formula, or if you have a milk bank, you can use donor milk.
Thank you, doctor. Bueno, menciona el doctor entonces con lo del fortificador, que generalmente se les da cuando tienen 50 cc aproximadamente, pero no es como que el gol principal, ¿no? Menciona todos los otros aspectos que tenemos que tomar en cuenta, sobre todo desde el primer día que se le empieza o se le intenta dar la leche materna, o la leche de donante, pero sin embargo, generalmente ellos empiezan cuando tienen como 50 cc en la UCI. La segunda, la cuestión de la dieta de las mamás. No hay ningún estudio, ellos no recomiendan con la consejería de lactancia que tienen, su enfoque más que nada es en cómo ayudar a las mamás a extraerse la leche, a hacer las tomas, de la posición en la que tienen que dar los bebés, pero no una recomendación en la dieta o algo que ayude. Claro, las mamás que son diabéticas, pues su leche va a tener mayor glucosa, mayor proteína, pero no hay una dieta como tal. Y la tercera, bueno, menciono igual en la plática sobre los estudios de estas máquinas que analizan la leche, pero son caras, todavía no son muy conocidas. Algo que se puede utilizar definitivamente es la medida del crematofrito. Este se puede utilizar para saber si la leche es hipocalórica o hipercalórica.
Un tema excelente que incluso en lo personal considero que pudiéramos pasar platicando sobre ese tema todo el día. Pero sin embargo, por cuestiones de tiempo, nos tenemos que despedir por parte de la Federación Nacional de Neonatología y de la Asociación del Colegio de Neonatólogos de Tabasco. Les agradecemos su participación y todas sus preguntas. Cedemos ahorita la palabra a la doctora María Mercedes Mercado, también para que se despida en nombre de la Asociación de Neonatólogos de Baja California.
Muchas gracias, doctor Santana. Doctor Hay, muchas gracias a todos. Sin duda, pues lactancia materna, una intervención con que todos la tenemos al alcance, simplemente es fomentarla y con grandes cambios en la evolución de los bebés y sobre todo en el neurodesarrollo. Nos despedimos de la Asociación de Neonatología de Baja California y le agradecemos siempre a la Federación Nacional, pues la invitación, la participación, que de alguna manera nos motiva mucho y estamos ahorita aprovechando los webinars que han sido un éxito. Le cedemos la palabra al doctor Garza para que nos haga la despedida de este webinar.
Bueno, pues muchas gracias, Dr. Hay. Thank you very much for your extraordinary presentation. Thanks a lot.
Very welcome.
As I told you.
Dr. Bill Hay, thank you very much. Thank you for sharing your experience.
It's my pleasure, and I enjoyed talking with all of you. I like the questions especially. Thank you.
Thank you.
Thank you.
Muchas gracias a la doctora Mercedes Mercado y al doctor Alberto Santana por la coordinación de esta sesión clínica. Al doctor Raúl Bisuet, mucho gusto compartir con usted aquí el foro, doctor. Un placer saludarlo.
Igualmente.
Y el agradecimiento al doctor Gaspar Encalada y bueno, al doctor Moisés Quiles por la invitación y la organización de este evento y los otros eventos que se han organizado y los que siguen por organizarse. Un placer tenerlos aquí con ustedes. Muchas gracias por parte de la Federación Nacional de Neonatología de México y que tengan un muy buen fin de semana. Nos vemos.